I would like to welcome everyone to an All Tribes webinar. My name is Anna Whiting-Sorrell, and I work for Kaufman and Associates, often referred to as KAI, and I am honored to be your moderator today. Today's webinar is titled Tribal Protections in Medicaid and CHIP Managed Care Oversight Toolkit. Please note this webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenter and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare and Medicaid Service. At this time, I am honored to turn this over to Beverly Lofton.
Thank you, Anna. Thank you so much. I'm Beverly Lofton. I'm a senior policy advisor in the Division of Tribal Affairs at CMS. So welcome to today's webinar. During today's webinar, our presenter will provide an overview of the statutory and regulatory tribal protections in Medicaid and CHIP and health insurance program managed care. Then our presenter will walk through the Tribal Protections Oversight Toolkit and highlight some of the tools, resources, and navigation features of the toolkit. Any materials related to this presentation can be downloaded from the Spotlight page of the CMS American Indian and Alaska Native Outreach and Education website at go.cms.gov/AIAN. The website link will be added to the chat of the webinar in the chat section. I'm now pleased to be joined on this webinar by Lane Treliger. She's a technical director in the CMS Division of Tribal Affairs. And at this point, I will turn it over to Lane. Lane?
Thank you, Beverly. We're going to do a PowerPoint presentation, just go over the Indian protections like Beverly announced, and then we're going to go over and I'm going to share my screen and we're going to go through the toolkit. Implementing the tribal protections in Medicaid and CHIP managed care. In 2016, the Centers for Medicare and Medicaid Services published a Medicaid managed care regulations at 42 CFR Part 438. The regulations codify the Indian managed care protections enacted by the American Recovery and Reinvestment Act and are found at Section 1932A-2C and 1932H of the Social Security Act. The Indian managed care regulations begin at 42 CFR 438.14 and are cross-referenced in Children's Health Insurance Program at 42 CFR Section 457.1209. The Indian managed care regulations apply to all contracts between state Medicaid agencies and managed care organizations, prepaid inpatient health plans, prepaid ambulatory health plans, primary care case management programs, and primary care case management entities. Indian managed care regulations. The tribal protections do two things. They allow American Indians and Alaska Natives enrolled in Medicaid and the Children's Health Insurance Program managed care entities to continue to receive services from an Indian healthcare provider, even if the Indian healthcare provider does not participate in the managed care plans network. Also, it ensures that Indian healthcare providers are appropriately paid by the state and or managed care plans for services provided to American Indian Alaska Natives. Indian managed care regulations. The regulations also address other tribal issues such as network sufficiency and payment requirements for managed care plans that serve American Indian Alaska Natives, network provider agreements with Indian healthcare providers, and referrals to network providers by Indian healthcare providers. The final rule is available at the link on this particular slide. CMS Informational Bulletin. On December 14, 2016, CMS issued a CMCS Informational Bulletin summarizing all the Indian managed care protections into a single piece of guidance. entitled Indian Provisions in the Final Medicaid and Children's Health Insurance Program Managed Care Regulation. The informational bulletin link is on this particular slide. Provider choice. American Indians and Alaska Natives enrolled in Medicaid and CHIP managed care plan can continue to receive services from the Indian healthcare provider of choice, even if that Indian healthcare provider does not participate in the managed care plans network. Also, any American Indian Alaska Native who is enrolled in a managed care plan and eligible to receive services from a network Indian healthcare provider can choose that provider as his or her primary care provider. A network Indian healthcare provider is an IHS, tribal or urban Indian organization that has entered into a contract with the managed care plan. Network sufficiency standards. Every managed care plan must demonstrate that there are sufficient Indian healthcare providers participating in the plan's network to ensure that American Indian Alaska Natives have timely access to services. In the event that timely access to Indian healthcare providers cannot be guaranteed due to few or no participating Indian healthcare providers, American Indian Alaska Natives enrollees have two options. They can access services from an out-of-state Indian healthcare provider, or they can disenroll from the managed care plan for good cause and switch to the state's fee-for-service program. Payment. When an Indian healthcare provider is enrolled in Medicaid or CHIP as a federally qualified health center or FQHC, but is not in the managed care network, the Indian healthcare provider must be paid the FQHC payment rate under the state plan, including any supplemental payment due from the state. When an Indian healthcare provider is not enrolled as a FQHC, the Indian healthcare provider must receive the Indian Health Service all-inclusive rate, published annually in the Federal Register, or the amount it will receive if the service is provided under the Medicaid state plan's fee-for-service rate, whether or not the Indian healthcare provider participates in the managed care plans network. Supplemental wrap payments. Supplemental payment. When the amount an Indian healthcare provider receives from a managed care entity is less than the error, the state must make the supplemental payment to the Indian healthcare provider to make up the difference between the amount the managed care plan pays and the error rate. Payment of the error directly to the Indian healthcare provider. States may contract with the managed care plan to allow the managed care plan to pay the error directly to the Indian healthcare provider. This payment arrangement allows the Indian healthcare provider to be paid the entire error and eliminates the need for the Indian healthcare provider to bill the state separately for the supplemental wrap payment. Next slide. Avoiding duplicate visits for referrals. Managed care plans must permit an out-of-network Indian healthcare provider to directly refer American Indian Alaska Native managed care enrollee to a network provider following the plan's utilization management process. This provision is intended to avoid delays in the treatment. This provision is intended to avoid delays in treatment by eliminating duplicate visits to a managed care primary care provider for a network referral. Next slide. Mandatory enrollment into managed care. A state must obtain approval from CMS either through a Medicaid state plan amendment, section 1932A state plan amendment, we call them SPAs, a section 1915B or C waiver, or a section 1115A demonstration to mandatorily enroll American Indians Alaska Native into Medicaid and CHIP managed care. States implementing Medicaid and CHIP managed care through a SPA waiver or demonstration application are required to engage in consultation with federally recognized tribes and/or Indian healthcare providers located in their state prior to submission of a SPA waiver or demonstration to CMS. Indian managed care entity. Section 1932H4B of the Social Security Act authorizes states to establish an Indian managed care entity. An Indian managed care entity can be a managed care organization, prepaid inpatient health plan, prepaid ambulatory health plan, primary care case management program, or PCCM entity. And Indian managed care entity is defined as a managed care entity that is controlled by the IHS, a tribal organization, or or urban Indian organization, or a consortium of any of these entities. Indian managed care entities may restrict its enrollment to American Indian Alaska Natives in the same manner as Indian healthcare providers may restrict the delivery of services to American Indian and Alaska Natives. CMS's efforts to implement the Indian managed care protections. CMS has been working with states and Indian healthcare providers to identify and resolve implementation and compliance issues on a state-by-state basis. To address the issues from a national perspective, CMS collaborated with the National Indian Health Board in 2021 to convene a managed care listening session and a virtual roundtable event. The roundtable was attended by tribal health directors and Medicaid staff to identify strategies and practices that states and managed care plans could use to successfully implement the Medicaid and CHIP managed care protections for Indians. National Indian Health Board produced a roundtable report that describes the recommended practice and strategies in great detail. There's a link to the report at the bottom of the slide. Medicaid and CHIP Managed Care Oversight Toolkits. CMS committed to developing a series of technical assistance toolkits to assist states in complying with the managed care regulations and to help improve state monitoring and oversight of their managed care programs. On October 30th, CMS announced the release of the Tribal Protections and Medicaid and CHIP Managed Care Oversight Toolkit. The toolkit provides resources for states, managed care plans, and Indian healthcare providers to use to maximize the benefits of Medicaid and CHIP managed care for American Indian and Alaska Native enrollees and Indian healthcare providers. This is part of CMS efforts to advance health equity, expand coverage, and improve health outcomes for individuals who rely on Medicaid and CHIP. Medicaid and CHIP managed care toolkits. On this slide, we're showing you all the three places that the toolkit is posted. First, so on November 7th, 2023, CMS released a SIB also announcing the Tribal Protection Toolkits and other oversight toolkits. The November 7th, 2023 SIB can be found at the first link. The toolkit can also be found on the managed care, one of the managed care pages of the CMS website at the second link. And then the toolkit can also be found on the Tribal Affairs Guidance and Resource page at the third link. This concludes my presentation of the PowerPoint, and we're going to switch over to the toolkit. This is the Tribal Protection and Medicaid and CHIP Managed Care Oversight Toolkit. What this toolkit provides resources for states, managed care plans, and Indian healthcare providers to maximize the benefits of Medicaid and CHIP managed care for American Indians and Alaska Natives and Indian healthcare providers consistent with the statutory and regulatory Indian managed care protections. One of our many goals with this toolkit is to make it as user-friendly as possible. To meet that goal, we added a lot of interoperability and navigational functions. This includes interactive links to navigate between sections of the toolkit, direct links to specific sections of laws and regulation, and navigate to resources within the toolkit. I'm going to go to the table of contents first. As you can see, this table of contents has a series of navigational tools. On the far left side, you'll see a Go button. The Go button will take you directly, these Go buttons will take you directly to the various sections. So you don't have to go through the whole toolkit. You can always navigate just to the section you're interested in. So what I'm going to do, demonstrate a few of the navigational functions before we go through the substance of the toolkit. So first, I'm going to navigate to section 1. Here we've navigated to section 1. And at the bottom of every page, you can go back either to the table of contents, which is the button on the right side, or on the left side, you can go back, you can go forward to the next section. So I'm going to go back to the table of contents. and go back to section 1 and show you, some of the things that are in this particular section. So section 1 is just the background and context for basically the development of the toolkit. So we talk again about the background of the Indian protections, and then we talk about go forward. I also want to highlight just one thing. If you see this, I just highlighted that, you can go and click on that link and you'll go directly to section 3 in case you don't want to go to section 2. So that's another interoperability. So I'm going to continue going through the background and context for the development of the toolkit. So we talk about the National Indian Health Board and the Managed Care Virtual Roundtable I talked about with the PowerPoint presentation. And we talk about the panelists and all kinds of details of the roundtable event. And then here we have some recommendations in the roundtable report. While this toolkit doesn't include all the recommendations from the roundtable report, this toolkit contains several, and we've developed a nice chart that says, like, if you want to look at engaging in tribal consultation, it's in section 4.1 of the toolkit. If you want to institutionalize knowledge of the Indian health system, that is in sections 4.2 and 4.4. So you actually get kind of a demonstration of where things are in the particular toolkit. Now I'm going to go down to the bottom. I'm going to demonstrate one thing. Every section in this toolkit has a series of endnotes, and they're contained within the section of the toolkit. So you don't have to, if you want to see a link to a reference in the toolkit, you don't have to go all the way to the back end of the toolkit to get to it. Each reference is locked within their particular section. So now I'm going to navigate to the next section of the toolkit, which is section 2. And this section is the Indian Health Service. It provides an overview of the Indian health care delivery system, which is comprised of healthcare facilities operated by the Indian Health Service, by tribes, tribal organizations under the Indian Self-Determined Education Assistance Act, and urban organizations under Title V of the Indian Healthcare Improvement Act. This section also outlines the authority for IHS tribes and UIOs to bill Medicaid and the Children's Health Insurance Program. So I'm just going to go through. I'm pretty sure you're familiar with what's in here. So first, we talk about the Indian Health Service and describe that. And I'm going to show you one interoperability function of the toolkit. As you can see, the IHS, there's a map to the IHS areas. I don't want to make anyone dizzy, but I am going to click on that link and go to it to demonstrate how you can go back and forth in the toolkit. So I'm going to click this link. This takes us to the Indian Health Service page with the with the locations. And now I'm going to navigate back. It does take me back to the first page of the toolkit, but I'm going to go directly back to section 2, where I was. So then describe various sections of the statute, Indian Healthcare Improvement Act. You also see at the bottom of the page, now that you're in section 2, you can go to the previous section or next section. The tribe facilities operated by tribes and tribal organizations talks about the urban Indian organizations and what they are. Because remember, the users of this toolkit may not have any familiarity with the Indian healthcare delivery system. So while it may not be critical for those attending the call today to go through this section 2, it might be critical for other users that are not familiar with the system to go through it. So now we go over the authority of section 1911 authority to bill Medicaid. And then the 1905B authority for states to claim 100% federal medical assistance percentage, FMAP. And now we're going to go to the next section, section 3. We're not going to spend very much time in this section because we just went over the Indian Medicaid and Children's Health Insurance Managed Care protections in the PowerPoint presentation. But I just want to show you that within these links here, let's say the 1932 link, I'm not going to click on it. That will take you directly to that section of the statute. It won't take you to the top of the statute where you have to scroll down and find the A2C provision of 1932. It takes you directly there. We've done that throughout this entire toolkit with anything that's in the body of the toolkit. So you don't have to scroll or look for a particular provision. A direct link has been created. So we're not going to spend time here. We talk about, again, mandatory enrollment into managed care. Background of the Indian protections again. Talk about the SIB, which we already went over in the previous presentation. Key managed care provisions, we've already gone through those. So I'm just going to scroll through them. And I'm going to go to the next section, so we don't spend that much time here because we've just been through there. So I'm going to go to the next section. Section 4. This section has 5 separate subsections that provide resources and strategies that states can use to improve state-tribal relationships in the implementation of Indian protections in Medicaid and CHIP managed care, including tribal consultation. 2, require managed care plans to maintain a tribal liaison position. 3, improve contracting between managed care plans and Indian healthcare providers by using the model Medicaid and CHIP managed care contract addendum. 4, develop internal processes to improve understanding of the managed care delivery system for American Indian and Alaska Natives and Indian healthcare providers. And 5, partner with state tribes to develop an Indian managed care entity. So now I'm going to go down and navigate to section 4.1. 4.1 is about tribal consultation. This section will provide an overview in the history of federal and state tribal consultation requirements and tribal consultation recommended practices from the roundtable to improve state tribal relationships in the successful implementation of the Medicaid and Children's Health Insurance Program, Indian Managed Care Protection. So the beginning of this, we go through the federal tribal consultation requirements, provided the user links to the executive order and the presidential memorandum and tribal consultation. And then we have a next section that discusses the CMS tribal consultation policy, has links to the CMS tribal technical advisory group. It has another link directly to the CMS tribal consultation policy. And then we have a subsection, tribal consultation requirements for state, Medicaid, and CHIP agencies. And so that discusses the tribal consultation requirements of R 2009, and also includes an CMS interactive map on the tribal affairs page, where you go into the interactive map and you just click on the state if you want to look at that tribal consultation policy, and that will take you to the list of tribal consultation policy, and then you just click on the consultation policy and you can review that. So we thought that was a nice addition. And then we continue tribal consultation requirements for Medicaid and CHIP. In addition, we made note of transparency regulations because they have tribal consultation requirements that may be a little bit more robust than what's in the state plan. And those apply to Medicaid section 1115A demonstrations. And then we go into the tribal consultation recommended practices from the roundtable report. And tribal consultation, and want to note that tribal consultation processes can vary between states. CMS assessed the success and efficacy of the state consultation processes for Minnesota, Oregon, and Washington in 2013 using case studies. So these links will take you to that those case studies that are on the CMS website in case you want to see. And I think it's interesting to note that those case study for those 3 states represent a lot of the key takeaways and recommended practice that came from out of the roundtable report. So now we just have a few of the tribal consultation practices from the roundtable report. Key leadership should engage with tribes and Indian healthcare providers. What goes into adequate tribal consultation notices. A suggestion to offer alternative means for tribal consultation attendance. Also assume that there are tribal implications for changes to Medicaid and CHIP program. Always assume there are, even if you don't see them. How the formation of consultation work groups are a good idea, can be helpful to the consultation process. And documentation and follow-up of items discussed during tribal consultation. So again, this section has endnotes in it directly for this particular section. So now I'm going to navigate to section 4.2. Section 4.2, this section is require managed care plans to maintain a tribal liaison position. This section explains the advantages of requiring managed care plans to establish a tribal liaison position to facilitate improved communications between managed care plans and Indian healthcare providers to resolve Medicaid and CHIP managed care issues. So we talked and we have set for the background. I guess I should stop now. You might see a background throughout the toolkit because we wanted every section of the toolkit to be able to stand on its own. So if an individual doesn't want to see section 1, 2, or 3, they just want to get into the meat of the toolkit, they go directly there, and we still provide a background for every section. So every toolkit section stands on its own. So this we came from kind of describe some tribal liaison responsibilities, and we want to thank our state partner in Oregon. They developed a tribal liaison position description that's online that you can look at and either duplicate, customize, or act. And we took these actual responsibilities from that position description, and it's their managed care organization. It's a care coordination organization, and Oregon requires every care coordination organization to maintain a tribal liaison. So it's periodic meetings and trainings, developing and disseminating educational materials, providing a single point of contact on eligibility or payment disputes. This is really important. So Indian healthcare providers and enrollees or probably most likely Indian healthcare providers, will have a point of contact. They don't have to go through all the administration of the managed care plans and try to figure out who can help them with their dispute, which should make it easier to resolve disputes. And then what we did in the toolkit is we spotlighted Oregon and Washington's establishment of a tribal liaison position to improve relationships between Medicaid and CHIP managed care plans and Indian healthcare providers. So first we start out talking about, what does the Oregon Medicaid program look like, and what do their tribal programs look like? So they have their tribes, and they have their Native American Rehabilitation Association Northwest, which is their urban organization. And right here, I'll just scroll up it really quickly. That is where the tribal position description is. So if you click on that, you may want to, like I said before, you may want it to duplicate that and embellish it, or just customize it for your own use. But it'd be really good to have that kind of thing in your pocket if you want to approach your state about making sure their managed care plans maintain tribal liaison position and how helpful that is. So we go a little bit more over the managed care delivery system in Oregon, and then we highlight Washington. And Washington does it a little differently. What Washington State did is they developed an integrated managed care contract. You may want to look at that. It's right here. That contract does quite a few things. First of all, it requires all plans to maintain tribal liaison positions. It also has an accountability function that when, let's say, staff turnover, the tribal liaison left, they would have to report that and report the appointment of a new tribal liaison. So there's an accountability function within that contract and the agreements the state has with their managed care plans. The other thing that's interesting about this managed care program is they call it integrated managed care contract, because they have the managed care contract addendum at the end of the contract, but they've also integrated within every section of the contract the actual addendum provision. So the staff person, the managed care staff person doesn't have to go to the end of the contract to find all the stuff that applies to an Indian healthcare provider. They have it embedded within each section of the contract. So I thought that was a very interesting function. It's a very interesting idea. And here we in notes again. Then we're going to navigate to section 4.3. And this is use of the model Medicaid and Children's Health Insurance Managed Care Indian Addendum for contracting with Indian healthcare providers. And a lot of you might be familiar with this addendum, but other users, plans, and some states may not be familiar. So it goes with the background of the development of the addendum. And then right here, you can go directly to the addendum. They could go directly to the Medicaid addendum and click on it and see what it looks like. And we highlight just some key provisions, not the entire addendum. So key provisions of the ITU addendum include cost sharing exemption for Indians and no reduction in payment. Enrollee option to select the Indian healthcare provider as a primary care provider and Indian healthcare provider right to make referrals. Payment of claims. Persons eligible for items and services from an Indian healthcare provider. Insurance and indemnification. That sometimes can be a big block to Indian healthcare provider and a plan entering into a contract because they require malpractice insurance. And then there's also another thing that happens a lot. States are not familiar, or plans are not familiar with the licensure rules, licensure of healthcare professional rules, that you don't have to be licensed in every state. And then finally, claims format. So that's the end of this section. I'm going to go to the next section. This section has some interesting tools and resources in it. Develop internal processes to improve tribal understanding of the managed care delivery system. So this section provides examples of internal processes states have implemented to improve American Indian and Alaska Native enrollees' understanding of Medicaid and Children's Health Insurance Program, managed care, and to address claims processing and reimbursement issues encountered by out-of-network Indian healthcare providers. So again, here we provide a background. Again, and I'll highlight one tool. In April 2017, CMS published a Promoting Access and Medicaid and CHIP Managed Care Toolkit, otherwise called the Access Toolkit. And what it was intended to do is to assist state Medicaid and CHIP agencies with implementing the requirements of the 2016 final rule, provide an overall framework and suggest metrics for monitoring provider network adequacy and service availability, and then also highlight effective pharmacy practices that states currently use to develop and monitor provider network and access standards. That toolkit has, it doesn't devote a lot of time to analyzing the American Indian, Alaska Native, or the Indian healthcare provider experience with managed care, but it does highlight the problems that have the payment issues, the access issues. And so that toolkit would be interested. And it also explored difficulties that American Indian Alaska Native enrollees have experienced in accessing specialty care from network providers through a referral from an out-of-network Indian healthcare provider. And also, the toolkit also highlighted issues where Indian healthcare providers should be, but have not been properly reimbursed by the plan because they're out of network. So that's an interesting toolkit to take a look at and resource. And what we found is, in addition to the recommendations in the Access Toolkit, similar recommendations to the improved internal processes were identified in the Medicaid Managed Care Roundtable Report. So we're not finding a difference, we're finding just consistencies. So I'm just going to go over briefly the different processes. Managed care plans should develop internal process to improve the assignment of American Indian Alaska Native enrollees to primary care providers. This talks about some strategies. I mean, a lot of times managed care plans use algorithms, assignment algorithms that are like zip codes and things, but this suggests some alternative, like looking at the historical use of the American Indian Alaska Native enrollee to a particular provider. So provide some ideas and some strategies. And now I'm going to scroll down. Managed care plans should develop tribal specific educational materials. And that would be really helpful. But what we did highlight is the Washington Tribal Building Guide. I just mouse over it a little bit. And that billing guide is really interesting because it doesn't just talk about managed care. It's a billing guide. It can be used by enrollees and Indian healthcare providers, but it shows you how to navigate both the fee for service and managed care delivery system, and to navigate between those systems if you want to disenroll from managed care and enroll back into fee for service. How do you accomplish that? They also have a section on billing that helps the Indian healthcare provider in billing. They also have a really nice tools embedded within that particular guide that gives tools for Indian healthcare providers to be HIPAA compliant. So I thought that was a really interesting resource. Now I'm going to go to the next process, the next internal process. Managed care plans should avoid automatic claim denials for claims from out-of-network Indian healthcare providers. This provides a few strategies that managed care plans can use, and states could put into their contracts for managed care plans to use to avoid those claim denials. Also, managed care plans should contract with as many Indian healthcare providers as possible. When a managed care plan enters into contract, noting that I think that everyone's familiar here that an Indian healthcare provider does not have to enter into a contract, but if they the managed care reach out to Indian healthcare providers, it might help strengthen relationships and help, eliminate maybe claim denials. They could use the Indian contract addendum. They could actually be closer to the Indian healthcare providers in their state or in their geographic location. And of course, there's links to the ITU addendum and 4.3 to this toolkit. There's only a couple more here. Managed care plans should pay the Indian healthcare providers the total IHS all-inclusive rate directly. And this is a big one. And I think there are several states that do this. I think it's Oregon, Washington. There's several states, I wouldn't know how many, but doing so eliminates the Indian healthcare providers having to balance bill or wrap bill the state, and really cuts down on administrative burdens for the Indian healthcare provider. And also you'll see that highlighting, there's a plan letter from California in the endnotes. They've been doing this practice since July 2018, and it gives you a link to the all plan letter that not only said pay the error directly to the Indian healthcare provider, but also required the plans to try to contract with every Indian health care provider in their area, their service area. So that's a really helpful tool. Now I'm going to navigate to the final section. Partner with tribes to develop an Indian managed care entity. This section describes a statutory framework that allows states and tribes to establish an Indian managed care entity, and highlights the work that Oregon, North Carolina undertook to develop the first Indian managed care entities. So first we start out describing the statutory framework for establishing an Indian managed care entity, and then the positives to developing the Indian managed care entity, getting tongue-tied here. So states seeking to address historic inequities and improve health outcomes for American Indian Alaska Native population living in their state may want to consider contracting with an Indian managed care entity as one way to pursue this goal. Development of an Indian managed care entity could provide an option for American Indian Alaska Native enrollees to select a tribal managed care plan that coordinates care of Medicaid services in a culturally competent manner and improves access to health services and health outcomes for American Indian Alaska Native Medicaid beneficiaries. So there's advantages. Promotes developing one of these entities could promote tribal sovereignty and provide additional financial resources for tribes. But the big point in this is tribes interested in developing an Indian managed care entity in their state should contact their state Medicaid agencies. Every state has a different, every state that has managed care has a different managed care delivery system under, I think we discussed in my earlier presentation, the different types of managed care that they can have. And they have different types. It can be a managed care organization, a prepaid, ambulatory, prepaid. I keep forgetting all the acronyms. And then they could have a PCCM or a PCCM entity. But you won't know that what the state has until you talk to the state, because they may have to submit a SPA, a waiver, or 1115 demonstration to get the state to have the authority to develop the type of Indian managed care entity you want to. Now we're going to do a spotlight on Oregon and North Carolina. They are the first Indian managed care entities. So the very first, you'll see in the very first paragraph, the Oregon and North Carolina PCCM Indian managed care entity is spas. These are approved spas, so you can click on these links and see what those spas look like. And then we describe the process that the tribes and the Urban Indian Organization and the tribe in North Carolina went about to develop their Indian managed care entities. Both their spas cover similar care coordination services. However, the Oregon PCCM spa authorizes individual Indian managed care entities that will be operated by each of the tribes in Oregon and a urban Indian organization. The North Carolina SPA authorizes a single PCCM entity, and in the process, the tribe and UIO in each state undertook to develop the IMCEs and highlighted below. The programmatic features of both IMCEs are also described, highlighting the IMCE service delivery area, eligibility, enrollment, and care coordination benefits. So first, this goes over the Oregon Health Program. It describes the Medicaid system and the tribal system. And then in Oregon, the toolkit talks about the development of the Oregon Indian managed care entity. Then it talks about, it describes a service delivery area for these, and this is very different than what you will see in North Carolina. Then it describes Indian managed care entity eligibility, which is also different than North Carolina. And then it talks about Indian managed care entity enrollment, which is also different from North Carolina. So what we want to do is showcase these may be similar care coordination services that are delivered, but they're very different in how they were developed, how their enrollment works, how their eligibility works, and services. The Oregon Indian managed care entity services, they offer the following PCCM services: intensive telephonic case management, face-to-face case management, operate a nurse triage advice line, develop enrollee care plans, provision of enrollee outreach and education activities. They operate a customer service call center. They implement quality improvement activities, including administering enrollee satisfaction surveys or collecting data to assess the performance for the Indian managed care entity. And they conduct some outcome measurement and provide outcome reports to the state. Next, this is North Carolina. Again, the toolkit showcases the managed care program and the Indian program. The EBCI operates Cherokee Indian Health Authority, which is a hospital-based delivery system that operates under the Indian Self-Determination Act. And this particular Indian managed care entity is entitled EBCI Tribal Option. So there are a number of links that'll take you to the EBCI Tribal Option. There's even a link at the very bottom of this paragraph that you can find materials related to the EBCI tribal option on the North Carolina Department of Health and Human Services fact sheet. And the interesting thing with the North Carolina option, a lot of opportunities have been offered to state expanded Medicaid. And so now that the EBCI tribal option is working through a number of state plan amendments to expand some of the services they deliver currently. So that's really exciting and beneficial for EBCI tribe options. The toolkit discusses the development of the North Carolina IMCEs, the service area, IMCE eligibility, IMC enrollment, and then the services. They provide the same services that Oregon does. However, because EBCI has a larger health system, they have behavioral health and long-term services and supports. They coordinate with those programs. They coordinate with the behavioral health systems and provider, and they also do as well with long-term services and support providers. So see all the endnotes for this particular section. And then right here, I navigated to them before, goes to the appendices and glossary of terms. So I'm going to stop sharing my screen and turn this back over.
Thank you for that. This is Anna again, and I am, I don't see any questions in the question and answer box or in the chat. Does anybody have a question? If you do, you can put that into the question and answer chat, or you can, which is located at the bottom of your screen. And then you can also, or you could raise your hand and we will unmute you so you could ask the question to the presenters. Lane, I would like to thank you for a very, very comprehensive review of the toolkit. And I would ask, the question I might have is there a place where someone who resides in a state might reach out to their state Medicaid program to ask about managed care, a tribal managed care entity like you presented today?
Yes, they would start by approaching their Medicaid agency. First, they would have to think, what do they have the capacity to provide? You know, are they going to look like these two Indian managed care entities that were developed in Oregon and North Carolina are I would say the simplest form of managed care delivered, but they provide huge benefits to enrollees and to tribes to coordinate their care to make sure that there's that loop. You know, you refer them out, you get that information back. So that type of care coordination is really, really important. There has been been at least one other proposal for full-blown MCO managed care organization. It hasn't come to fruition yet, but it was proposed and they've been working on it. So they would first go to their state, think about, well, what do I think I can do? What can I accomplish? And then they go to their state and say, okay, this is what we're thinking about. What can you help us? Will you be interested in partnering with us to develop this entity? And I think it's one thing I didn't cover in the toolkit, but it's in the roundtable report, I believe, is that the care coordination fee it's on top of the error rate. I just want to make sure I pull that out. I did not put that in the toolkit. They get paid the error rate for the services, but they also get this care coordination fee. It's on a per member per month basis. So everyone that the tribe or the UIO enrolls into their managed care plan, they get a set cost that they negotiate that with the state to provide that service every month. And when they enroll, they have kind of interoperability with the state and the Indian managed care entity to say, okay, we have these people, and then they get the payment back. And EBCI tribal option works similar. So they do have to build in some interoperability between the state Medicaid agency and the Indian managed care entity. And that was one of the one of the many things that the tribes that developed these entities had to engage in, but it worked. It took each one of them about 3 years to develop these two programs.
Thank you for that. Just a quick follow-up question. Has this toolkit been sent to the state Medicaid offices? Or would that might be a first step? Someone might send it to them.
Yes, the toolkit, it was attached to the November 7th SIB that just went out. It was one of 4 toolkits that was sent out to all states. Informational bulletins go.
Okay.
And then they released a press release announcing the tribal toolkit as well on 2 other occasions. So I think that it's been advertised. We did release this toolkit, only not that long ago. So I think states have a lot of work to do with unwinding and so forth. But it's good to start because we're really interested in helping that process. It's a very interesting process they've gone. And also the first Indian managed care entity to start operating was the Urban Indian Organization, NARA Northwest. And so they're a really good resource, and they like to provide technical assistance to other tribes interested in doing the same thing.
All right. Well, thank you for answering that. Are there any other questions? Okay, I'm not seeing any in the question answer box, or I don't see anyone's hand raised. So I am going to go ahead and turn this back over to Beverly for closing remarks.
Okay, great. Thank you, Anna. Thank you so much, Lane, for a great presentation. So we don't have any questions in the chat, or no one is raising their hands for a question. So yeah, I guess you handled all the questions, Lane. You did a very thorough presentation. Thanks so much. So I would like to thank everyone for their participation in this webinar today. And just to remind you, a copy of the webinar will be found on our Spotlight page. And again, that's at the American Indian and Alaska Native Outreach and Education website. And you can find that at go.cms.gov/AIAN under all tribes calls. And you can always submit inquiries to the CMS Division of Tribal Affairs to our mailbox. So you can find our mailbox at tribalaffairs@cms.hhs.gov. With that said, we can close out our webinar, and everyone have a great afternoon.